Hi everyone, my name is Navdeep. I'm a registered nurse and I work as a community nurse from last 3 years. And today I have come up with a topic about insulin. We all use insulin in our day-to-day practice. We do a lot of injections, maybe 3 or 4 insulins a day is quite normal in community nursing. But I found that we do a lot of focus on injection techniques rather than understanding the actions and the duration of action of the insulin and its contents. So today I have started from the basic understanding of what is insulin, just gone back to our days of our first year of anatomy and physiology, starting back from the pharmacology of insulin. So without wasting our time, let's begin. So insulin, it's a polypeptide hormone which is produced in the pancreas from the beta cells. And these cells are situated in the aisles of Langerhans in the pancreas, and this helps glucose to move the to utilize glucose by our body. How? Because it moves glucose into our body cells. Otherwise, glucose just stays in the bloodstream. So insulin is actually helping our body to utilize that glucose to produce energy. This is a structure of insulin. As you can see here, there are two chains, which is chain A and chain B. So chain A has 21 amino acids and chain B has 30 amino acids, and these two chains are interconnected with sulfur-sulfur bonds. So this is the structure of insulin, and in total insulin has 51 amino acids. So hence why it's a polypeptide hormone. This picture shows some interaction between the liver and the pancreas and how glucagon and insulin are trying to keep the normal balance of glucose in our bloodstream. So as you can see here, let me see if I can grab a highlighter or a laser pointer. Yeah. When the blood sugar levels are low, then our pancreas releases glucagon, which goes into the liver, and liver releases some glucose into the bloodstream. As you know, liver has glycogen stores, so that glycogen is converted back into glucose, hence why that glucose is released into the bloodstream again to keep normal levels. But what insulin does is, when the glucose levels are very high in the blood, then it promotes the release of insulin from the pancreas, which goes into the liver through the portal vein, and liver eventually lowers the blood glucose levels by increasing the consumption or the uptake of glucose. So that's how glucagon and insulin try to keep a balance of blood sugar levels in our body. So glucagon is increasing the blood sugar levels in the bloodstream, and insulin is decreasing the blood sugar levels in the bloodstream. This is another picture that shows you that pancreas is sending some insulin into the bloodstream, and in the bloodstream you can see there is excess glucose. That excess glucose then binds with insulin and it's used by the cells of the body to produce energy. So there are some other functions of the insulin. What actually happens with the liver is, insulin is promoting the transport of glucose from blood into the hepatocytes. Hepatocytes are the cells of the liver where it is converted into glycogen, fatty acids and triglycerides. In our skeletal muscles, insulin helps in the uptake of amino acids and glucose from bloodstream. Those amino acids are converted into proteins, and glucose helps generate ATP, which is energy in the skeletal muscles. And then in adipose tissue, it helps with the uptake of fatty acids, which are converted into triglycerides. So why is insulin so important in diabetes? As diabetes is a metabolic disorder, there is deficiency of insulin in the body, or insulin is producing Insulin is being produced by pancreas, but our body cannot use it. It has got a resistance to insulin or insulin resistance. So hence where insulin injections may or may not be required in diabetes management. So insulin is only commenced when all other therapies have failed. It is commenced where other diabetes, anti-diabetic medications have failed to control the blood glucose levels, dietary modifications have also failed, and the exercise has also failed to maintain the healthy blood sugar range. So in that instance, insulin is used or prescribed. So with the courtesy of some images that I've used from Diabetes Australia website, we will try to understand different types of insulin. So first one is insulin glargine, which is usually a longer acting insulin or a basal insulin, and it is used only once in a day. So some of the common long-acting insulin brands used in Australia are Toujeo or Opticillin. These are both insulin glargine, but there is different strength in both of these. Toujeo is about 300 units of glargine per ml, and Opticillin is 100 units of glargine per ml. So the strength of glargine is different, but both of them are glargine. As you can see in the diagram, just look at this blue line. This tells you that this acts in our system for 24 hours. It says it has a longer duration of action. It is like Toujeo is quite longer, 24 hours. Opticillin may be a little lesser. So this keeps the blood sugar levels stable for a longer duration of time, and the onset of action is within 2 to 4 hours of injection. So usually that's why they are not sometimes coinciding with the meal times, and they are given, like here it's given at bedtime. So the main purpose is to keep the fasting blood glucose levels stable. This is the main function of longer acting insulins, but sometimes they can be administered at different time of the day as well, given other factors, like some people may be needing assistance with their insulin injection, so they can't have their insulins at night, so we sometimes go and administer them in the morning time as well. But the thing to remember here is it is a basal insulin, and it is going to work for longer duration, maybe between like 12 to 24 hours somewhere. Next is the intermediate acting insulin or basal insulin. Again, intermediate acting would be a bit shorter acting than the Toujeo or glargine, but this is also acting for quite a fair bit of time. So mainly in this situation, these insulins are also given once a day, and the common one in use is insulin isophane or protafane. This is the device you may have seen, protafane device, and we also use some vials, Humulin N, Humulin NPH. This is human insulin. So you can see here the insulin levels, the effect has gone down around dinner time, and when the client has a meal, blood sugar goes up, then we administer it again at close to the meal times, and then it will keep it doing its job for the next 10 to 16 hours. So in the previous slide you have seen the duration was 24 hours roughly. For Toujeo it was longer, whereas for protafane and for Humulin NPH the duration of action is 10 to 16 hours, and the onset is within half an hour to 1 hour. So it starts working more quicker compared to Toujeo and glargine, the Opticillin, but the duration is shorter than Opticillin or Toujeo. It is 10 to 16 hours, whereas in those it was 24 hours. Next is rapid acting insulin. These are most commonly we see Novorapid in our situation. We see a lot of clients are being put on Novorapid. As the name says, rapid acting bolus or mealtime insulin. So this always need to be given at mealtime. See, the person has breakfast, we give Novorapid at the same time, because the onset of action is it starts acting really quick. It starts acting within 5 minutes and it stays in the system for 4 to 5 hours until the next meal time. So Nova Rapid needs to always be given with the meals when the meal is right in front of the person. So you can see the onset starts within 5 minutes. It is so quick acting. Other brands are like Humalog, Apidra, Fiasp. We haven't seen these very commonly. Nova Rapid is the one that's more commonly seen in my experience being a district nurse in most of the clients' houses. Another one is Act Rapid, Humulin R. These are also bolus insulin. They start acting really quick within 30 minutes, and their duration is also up to 6 hours, just like Novorapid. So these are also given at meal times, as you can see in this diagram. Just before the meal, this is given, and then the effect wanes off around next meal time, and then again at lunch it's given, the effect wanes off at next meal time, and then again at dinner and the effect wanes off. So these are mealtime insulins. Now, as you have seen that there are too many doses of injections. One is a basal, and then if a person is also taking 3 times, it sometimes become difficult for them. Sometimes there are other comorbidities, other medical conditions like dementia, or they may be having arthritis. They can't use the devices to do the injections themselves. So in those situations, to reduce the frequency of insulin injections, some newer insulins are prescribed nowadays. We see them a lot, like Novomix. We see Novomix, and we also see Rysodeg quite often in people's homes. So these are usually BD regimes because these are mixed insulin. They have a combination of a longer acting and a shorter acting component. So rapid acting and longer acting in one insulin pen. So these are mixed insulins. So that's why these don't need to be given that often. This can be once a day, this can be twice a day based on the blood sugar levels or glycemic target of that person. So the onset needs to be checked here. See, for Novomix and for Rysodeg, as these are the most common ones we see, so the onset is 5 to 15 minutes. So here also we need to make sure that the person is eating just after we administer insulin. We can't leave the person after administering Rysodeg thinking that this is not a rapid acting. No, it has got a rapid acting component. See, it will start its onset of action within 5 to 15 minutes of administration, and it will stay in the system for 10 to 16 hours. So it works for longer duration. That's why they don't need to be given with every meal, but they can be BD or OD administration based on the individual plan. So you can see here, you can see human, premix human and premix analog insulins. So premix human brands used are Mixtard, Mixtard 30 and Mixtard 50. So these are both premixed insulin, but what is this analog and what is this human? Why, if they are both premix? See, the onset of action is 5 to 15 minutes in analog insulin. They are more quick to act, whereas here in human insulin, it is 30 minutes. They take 30 minutes to kick in. Whereas here, the duration is almost same, 10 to 16 hours. So what's the difference between human and analog insulin? So I just did a bit of quick search. Even I didn't know about that before. So human insulin it's a lab generated insulin. It is both are synthetic insulins, human and analog. So but it has same amino acids as the actual human insulin, same 51 amino acids as the real human insulin. Whereas analog insulin can have, it is also lab generated, but the amino acids can be different from the human insulin because we need to change them into rapid acting or longer acting. So based on the duration of their action, there may be difference in their amino acids, and some insulins, pre-mixed insulin, are also analog insulin. And some studies have found that analog insulins give more tighter blood glucose control compared to the human insulin. So that's why in practice we are seeing more use of analog insulins like Novomix, Rysodeg compared to the human insulins. So these are the references that I've used for this presentation. you like it, please share, comment, and subscribe to the channel. This channel is mainly for education, and it's good to learn from each other. So I would really appreciate your comments on the topics that you would like in the future.